Hello and welcome. I'm Sam and I will be describing a research poster titled Building a Community of Care Supporting Migrants with Acquired Disabilities. This poster is created by the Disability Migration Network, DMN, based on a research project conducted by the DMN and the International Labour Organization, or ILO, Triangle. The poster has a creamy brown and pale colour scheme and is divided into several distinct sections with charts and text. I will now describe the layout and read all the content. At the very top, the title is in large, bold letters, Building a Community of Care, Supporting Migrants with Acquired Disabilities. Below that, the authors are listed as the Disability Migration Network, or DMN, and the International Labour Organization, or ILO, and it says the work is forthcoming. The first block of text, which is the background and rationale, states, this poster evidence is extracted from a broader study that aimed to understand the disability dimensions of labour migration in the ASEAN region. This poster focuses on the continuity of care for migrant workers with acquired disabilities, an often overlooked aspect of migration health and social protection, highlighting the challenges migrant workers face after accessing healthcare, from rehabilitation, community support and compensation after acquiring a disability, and outlines the need for coordinated cross-border mechanisms to ensure sustained care, job retention or reintegration. Directly below that, a second header reinforces the objectives. The wider study explores the different dimensions of disability within labour migration. This poster aims to explore the continuity of care for migrant workers with acquired disabilities while abroad, highlighting gaps and opportunities for more inclusive cross-border health and reintegration support. Now, moving towards the main body of the poster and method section. It is organised into three sections. To the left, we have the Design, Data Collection and Analysis section, and on the right we have a QR code leading to an external chart. Design, mixed methods research combining quantitative and qualitative approaches. Data collection, conducted with Cambodians, Indonesians, Myanmar, Filipinos and Thai nationals, through 55 structured surveys with migrant workers with disabilities, 25 with acquired disabilities, and 11 key informant interviews with government, employers, trade unions and migrant service providers. Supplemented with data from the ILO and IOM 2024 survey of returnee migrant workers in ASEAN. Analysis. Quantitative data analysed using SPSS for ILO IOM 2024 survey. Qualitative data coded thematically following the labour migration cycle to identify risks, gaps and patterns of disability responsiveness. The QR code to external chart shows a chart depicting the journeys of all 55 participants we interviewed, split into 4 sections. 1. Disability Migration Group. 2. COO. 3. COD, actual or desired. And 4. Sector they worked in. The next sector is the analysis, which is the bulk of the poster. It is split into 2, first on the left going top to bottom and then on the right going top to bottom. It starts with a pie chart titled Circumstances of Disability Onset. The chart shows 60% acquired disability whilst working, 12% on premises but off duty, 24% off work hours or premises, 4% on holiday. And below that, a second pie chart shows the causes. 44% were workplace accidents, 28% were road accidents, 20% were due to medical conditions, and 8% were slips, falls and trips. Now we move to a different results section from A to E. Section A, Accessing and Affording Medical Care. Section A is about accessing and affording medical care. There are 3 line charts. Chart 1, Immediate hospital care after injury. 76% received immediate hospital care. 24% faced delays due to employer decisions. Chart 2, Hospital stay. 16% stayed less than a week, 52% 1 to 4 weeks, 24% stayed 1 to 12 months, 8% over a year. Chart 3. Hospital cost coverage. More than one option selected. 64% was covered by employer contribution in part or whole, 12% by private insurance, 20% by self-payment, 4% by government aid, 20% was family funded, and 20% third party. Under concerns, it lists financial barriers to accessing quality healthcare moved around different hospitals and slow onset conditions, for example in domestic workers, were difficult to identify by screening. Language barriers and poor communication impacted outcomes, with some information given without explanation or translation. Out-of-pocket expenses led to debt burdens, delayed treatment, and incomplete recovery. While illustrative accounts revealed negligence and inadequate post-surgery care, contributing to gaps in migrant-sensitive health protection and continuity of care. Section B covers rehabilitation. There are 3 more line charts here. Chart 1. Received rehabilitation. 80% received some form of rehabilitation. 20% did not receive any kind of rehabilitation. Chart 2. Access to rehabilitation. 50% received it in the country of destination, 42% in their country of origin, 8% in other countries. Chart 3. Funding sources. More than one option selected. Myself, 21.1%. Employer, 36.8%. Private insurance, 10.5%. COO social services, 10.5%. Third party, 10.5%. Family, 26.3%. And don't wish to answer, 10.5%. There are 2 QR codes with the text, "Scan the QR code to explore a true migrant rehabilitation journey." 2 quotes are featured. An Indonesian migrant says, "The therapist showed me how to walk properly and how to sit down properly." A Cambodian migrant says, "No one translated for me. I couldn't understand what was happening." Under concerns, it lists cost, distance, language barriers, and lack of information that can lead to financial strain and emotional distress. Section C moves to the right-hand side of the results and focuses on community life after leaving the hospital. It states 52% remained in the country of destination for 6 weeks or more after leaving hospital. There is another QR code. Scan the QR code to learn about community life after acquiring a disability post-hospital. A specific story is shared. A Filipina migrant in Thailand who had 2 caregivers who were funded by her family to take care of her basic needs like cooking, availability, bathing, dressing, and toiletry. But they were unable to understand each other, which increased her loneliness and isolation. Under other migrant testimonials, 2 powerful quotes are given. "I cried all the time. My housemates also cried every time they left. I could not even bathe and was bedridden. I couldn't leave the house, so I asked friends and acquaintances to buy food for me. When my friends went out, I was left behind because I couldn't move around well. I was left behind." Section D is about disability compensation. A line chart shows 44% received compensation, which was often minimal. 55% were not compensated at all. Under concerns, it states lack of awareness of entitlements or claims process. There are 2 QR codes. Scan the QR code to know how migrants pursue their disability compensation claims. 1. It highlights the case of a Myanmar migrant worker who experienced language barriers, fear of retaliation, and physical mobility issues preventing him from pursuing claims. 2. Another Myanmar worker's disability claim took years before payout, and it was insufficient to cover his debt. The final data section, E, looks at employment after disability in the country of destination. A chart titled Post-Disability Status with Employer shows 76% did not return to work abroad after injury. 24% remain unemployed with their previous employer. Another chart on unemployment reasons shows 42% were dismissed, 24% returned home voluntarily, 16% forced to return home due to health or lack of support. Under concerns, it states, employment continuity depended on employer goodwill, informal adjustments, and personal resilience, not policy frameworks. There is a final QR code. Scan the QR code to follow a true story of rebuilding a career after acquiring a disability, which shares the story of a Filipino migrant worker's experience with post-disability employment and neglect. Key findings and recommendations. At the bottom right of the poster, there is a section titled Key Finding and Recommendations. It lists several key points. Beyond hospital discharge, while most participants accessed emergency or surgical care, continuity of care was weak, with little structured support after leaving hospital settings. Reliance on informal networks. Recovery often depended on personal networks, leading to financial strain, loss of income, and emotional isolation, highlighting the absence of formal post-acute care systems. Invisible phase. Limited post-hospital support leaves workers in limbo, not fully healed, employed, or supported. Lack of counselling and community-based care delays recovery and reintegration. Isolation and mental health distress emerge as major invisible impacts of acquired disability. Families can incur long-term financial and caregiving responsibility, often leading to debt and lost income. True disability responsiveness requires continuous, rights-based care that extends beyond hospital walls. The recommendations are: create accessible, portable disability compensation and insurance schemes that cover long-term impacts of acquired disabilities. Design return-to-work programs and employer incentives within BLA to support retention and workplace accommodation. Establish collaboration among governments, employers, workers, and NGOs to build peer support, mental health, and community-based rehabilitation systems across borders. And ensure persons with disabilities are included in migration health data, monitoring, and policy consultations. In the bottom left corner, the acknowledgement section reads, "The poster draws from the collective efforts of the DMN team, members and partners, with support from the ILO. We thank participating organisations from governments, trade unions and employers' organisations, and the participating migrants with disabilities, whose collaboration and lived experiences made this research possible." That concludes the description and reading of the Building a Community of Care poster. Thank you for listening.